Welcome back, everyone. I hope it has been a great day so far, and I, Fatma Gohar, welcome you back as part of the Student Organizing Committee and the President of the Neuroscience Interest Group to the inauguration ceremony of the third annual Neuro-Oncology Symposium. A series of excellent, inspiring, and noteworthy sessions, one after the other, has led us to this ceremony. We are honored to have been joined by global speakers, faculty, attendees, and our medical students, making the first day the success that it has been. I cannot go on without mentioning the organizers of the third annual Neuro-Oncology Symposium, which are the Al Khan University, Pakistan Society of Neuro-Oncology, PASNO, Pakistan Academy of Neurological Surgery, PANS. Our collaborators, the Pakistan Society of Pediatric Oncology, Brain Tumor Foundation of Pakistan, and the Neuroscience, Surgery, and Student Oncology interest groups at the Al Khan University. I would like to and am honored to invite the chair of the organizing committee, consultant pediatric neuro-oncologist and associate professor of pediatric neuro-oncology at the Al Khan University, Dr. Noreen Mushtaq, to begin this ceremony by giving the opening address.
Bismillahirrahmanirrahim. Assalamu alaikum. Good afternoon, everybody. I welcome you all in third Pakistan Annual Neuro-Oncology Symposium organized by Pakistan Society of Neuro-Oncology and Al Khan University Hospital. Today is surely a day to celebrate because we are all here after 2.5 years of COVID. At this point in time, we have more than 200 participants joining us physically, and two of our esteemed speakers who came all the way from US, Dr. Reed Thompson and Dr. Michael Diwan. Thank you so much for coming to Pakistan and support us. And not only this, we have more than 200 participants who joined us virtually also. So with this, the Pakistan Society of Neuro-Oncology, under the leadership of Dr. Athar Inam, has evolved magnificently over the past few years. And since then, since for the last 8 years, we have seen various invention and innovation which is happening in this super specialized field of oncology, also pediatrics and adults. So neuro-oncology has now recognized and one of the most emerging fields in Pakistan. So for the past 8 years, we have seen immense growth with PASNO, that our tuning initiative with the Hospital for Sick Children, Toronto, the establishment of neuro-oncology, neurosurgery, and pediatric oncology fellowships at AKU, the development of various pediatric brain tumors guidelines, national guidelines, and the development of twinning programs and national initiative as national tumor boards in Pakistan. So this all leads to an immense growth. And I'm pretty sure that at some point in time, we may lead the LMIC in the field of pediatric neuro-oncology. And it will be a model for many countries in the low middle income countries to, follow our path. So with this, I would like to invite Dr. Athar Inam, who is the president of Pakistan Society of Pediatric Oncology, who is the, not Pakistan Society of Neuro-Oncology.
Thank you, Noreen. Probably it meant something when you said pediatric oncology. And I have done it many times, and I'll do it again. Embarrass Noreen by saying that she is my role model. So she has been my role model, the way she has handled neuro-oncology in Pakistan. After she was trained in Toronto with Eric Buffet, the way she has single-handedly made so much difference in Pakistan in the landscape of neuro-oncology that it's just amazing. The Pakistan Society of Neuro-Oncology was formed 3 years ago because I've been in Pakistan for about 19 years after my training in USA, and I noticed that there are a lot of standards that are missing. I mean, even simple things like getting an MRI after a craniotomy for brain tumors, it was a struggle to get it done within 48 hours. I was called repeatedly after every surgery by technicians in the MRI that, hey, this man has staples. Can we do an MRI? And I would say, yes, you can do an MRI. That's fine. And this went on for maybe a few years. Slowly that died off, and the meme started to catch on that yes, you can do the MRI, and the MRI needs to be done within 48 hours. But then there was a lot of resistance in getting this meme spread across the country, and I think slowly people are catching up on it, and we are talking about the standards that we have. But at the same time, while we try to follow these standards, which come from North America, Europe, and Japan, and countries like that, which is which goes through rigorous testing and rigorous scientific protocols, we realize that there are things which are unique for Pakistan. There are things that we cannot just force upon the neurosurgeons or the neuro-oncologists in Pakistan. We cannot force a round peg in a square hole kind of a situation. And for that purpose, the society was a requirement. So the Pakistan Society of Neuro-Oncology, its vision is to nurture and train global neuro-oncologists. And that's what we want to do by doing all these activities, which include teaching and training and networking and trying to build up relationship. But then the eventual goal is to improve the outcome for the patients, to improve their treatment. That's the eventual goal. And for that purpose, we have a sister organization that you would be seeing now and then, its logo, which is Brain Tumor Foundation of Pakistan. So BTF PAC, Brain Tumor Foundation of Pakistan, that is headed by someone named Ms. Komal Sayed. She lost her husband to a brain tumor, and she chose to devote rest of her life trying to make things easy for the brain tumor patients. So that's our sister organization, BTF PAC, and Komal Sayed is the leading person on that one. So this year, the three annos, and the three annos words come from third annual Neuro-Oncology Symposium, and annos is also a word that is used in Spanish language, means years, annos. So it's the third year. So that fits very well. So in the three annos, this is unique this year because we have, first of all, started the Rosenblum keynote lecture series. He asked me not to mention that he was my mentor, so I did not mention that when I was introducing him, but he has definitely imprinted that thing on me. And we had great speakers today. And after that, the second thing, which is very important, and I hope that stays like that, is that the pediatric neuro-oncologists have joined us, and we are doing it together. So joining hands together and doing it, we were never fighting, right? I mean, you're my role model, so how can I fight with my role model? But this is something that we have started this year. And the third thing actually that's happening is this hybrid, because the last 2 years were totally virtual. Hopefully next year we will have totally physical. So we are so very glad and so very honored to have our two special guests flying all the way from USA. And I think we have clapped already, but I want to have a clap again for these people to really come in at this time when there was an advisory against traveling, I think, from US government. Maybe you didn't read it, right? You missed it. Huh? There's always something. So, but there's no flood here right now. So that has given a lot of life to this symposium, and we look forward to some great speeches that we have lined up, and we will introduce our worthy and honorable speakers as we go along. So once again, I welcome all of you, those who are here and those who are online, to this three annos and making it successful. Thank you very much.
Thank you, Dr. Inam. Now, I would like to introduce Dr. Muhammad Tariq before inviting him for his address. Dr. Muhammad Tariq is the Vice Dean of the Medical College at the Aga Khan University. He is also the Yasmin and Shaukat Ali Jasani Endowed Professor, Section of Internal Medicine, Department of Medicine at the Al Khan University Hospital. He also has a joint appointment at the Department for Educational Development at the Medical College at the Al Khan University. Dr. Muhammad Tariq.
Thank you. Assalamu alaikum, everybody. And good morning and good evening. And good morning to others. Maybe you are listening from USA. So it's an absolute pleasure. And I'm so delighted to be here among such qualified healthcare professionals in neurological surgery and neuro-oncology, as well as neurology. Thank you, Dr. Athrinam, Dr. Noreen Mushtaq, Dr. Shazad Shamim, Dr. Salim Islam, and all the other who are in the administration of this symposium and the conference, as well as the Pakistan Academy of Neurological Surgery and Pakistan Society of Neuro-Oncology for inviting me to speak at this occasion. We are so proud of the work the faculty in neurology, neurosurgery, and neuro-oncology is doing, as well as student engagement in the field. The Dean of the Medical College, Dr. Adil Haider, because of the prior commitment, is unable to come today, and I am representing the Medical College on his behalf. It makes me very hopeful and I'm extremely hopeful that we have representation from across the globe in this conference. Such a diverse, multidisciplinary collaborations is very much needed in the field. The lineup of experts, which is there, which is increasing day by day with diversity, and it's extremely important. And each year the diversity is increasing, and which is a potential for learning for all of us. So that's very, very important. We must nurture and produce leaders in neuro-oncology in Pakistan and the region. And such initiatives are really needed to enhance neuro-oncology in the country. And we need neuro-oncologists because brain tumor, we are seeing more and more patients in brain tumor. As an internist, I am a physician, professor of medicine. I see a number of patients with headaches and a number of other symptoms, and come across neurosurgical issues and surgical oncology patients with me, and then refer these patients to neuro-oncology. So that's really a need and such initiatives. So as a vice dean of the medical college, I'm really very happy and excited to attend these kind of sessions where a multitude of different critical topics are discussed and under considerations. So at AKU, our primary mission is to improve the quality of our healthcare, as well as the quality of the community. And exactly what you are doing through this conference to improve the quality. The field of neuro-oncology has come across long way in the last few decades, and with few therapies and techniques emerging, new techniques are emerging that have positively impacted the outcomes in neurosurgical, the pain management, and a number of other things. 30 years ago, very few people were researching brain tumors, and now it's becoming more and more common. And with this advent, now this conference was started in while there was a COVID pandemic going on, and I think thanks to Dr. Inam and the team who initiated 3 years ago in 2020, and a group has developed. So I think this is really encouraging. At that time it was started, and this is now the third one, and it is increasing day by day with attendance of, and particularly neurosurgical students interest group. I think those really, they are admirable. They are supporting this conference as well. And being a scientist, researcher, and a clinical educator myself, I'm really very much this is extremely close to my heart. I'm really excited. The future of neuro-oncology looks extremely bright, and leaders such as yourself and all of you, particularly, I'm really thankful to the international delegates who are here, as well as national delegates. So because of you people, I think this is emerging more and more. And at the end, thank you to our collaborators, including Pakistan Society of Pediatric Oncology, Brain Tumor Foundation of Pakistan, NSIG, SOIG, I think it's a student interest group, as well as surgical interest group. And thank you to the entire team that works behind the scene to make this conference a success. Particular thank to Dr. Noreen Mushtaq and Dr. Shazad Shamim for organizing this, and all the team and all our speakers, panelists, and moderators for giving your time and share your expertise. Thank you so much, everybody. Thank you.
Thank you, Dr. Tariq. Now I'm honored to invite Dr. Salim Islam, an Al Khan University alumnus and the Qaid-e-Azam Professor and Chair of the Department of Surgery, Al Khan University Hospital.
I promise to keep it short because I'm clearly the last one between, what you really are here to hear. And I'm really a brand new chair, like 4 days old chair. So that's as new as it gets. But it's exciting for me to see a symposium of this nature taking place. And it's really truly a testament to the strength of the academics in this institution, which crosses silos from neuro-oncology to neurosurgery. And what I've learned in these 4 days is neurosurgery is a powerhouse in this institution. And nothing is an accident, and it comes from true leadership that has occurred at the highest levels, from Athar Inam and Shazad and all of the groups there that I've met. They're just clearly outstanding. And I think our folks from Vandy can testify to their expertise. And so that's been a wonderful thing. One thing that this conference is showing us is that the world continues to get smaller. And the whole idea of global collaboration is truly visible when we see our visitors who are here today and the folks who are online. And it's when we have these collaborations of this nature is when we can really enact powerful change in the world. And so we hope to see that moving forward. And despite all the hospitality that our guests from Vanderbilt are going to see, I remain a Gator, and I hope they beat them this year as well.
Good evening. Assalamu alaikum. My job here at the moment is to introduce our first keynote speaker for tonight, Professor Reed Thompson. Professor Thompson is the William F. Meakin Professor of Neurosurgery and the Chairman of Department of Neurosurgery at the Vanderbilt Medical Center. And he's been the chair for more than a decade now, so that says something about him. He also holds a secondary appointment as Professor of Otolaryngology at Vanderbilt Medical Center, which, if you don't know, is a center with a rich history in terms of otolaryngology and neurosurgery combined. And I've been told that next to the House-Brackman the center which introduced the House-Brackman scale, Vanderbilt Center is the most widely known for its expertise in skull-based, especially acoustic neuroma surgeries. His clinical interests are in all aspects of neurovascular surgery and brain tumor surgery, including skull base. He serves on the joint section of cerebrovascular surgery for the American Association of Neurosurgeons and the Congress of Neurological Surgeons. But more importantly, Dr. Thompson has been a guide and a mentor for many of our own graduates over the years. In fact, a little known fact is that he is a mentor for quite a few of our faculty for this conference, including one of our keynote speakers. I will not name the person. And from the interactions that I've seen him had over the last 36 hours, I can already see that he'll be a mentor for a lot of other of our graduates in the years to come. And I'm so grateful that Dr. Thompson could fly half around the globe to come and visit us tonight and deliver his keynote lecture. So Dr. Thompson, over to you for a keynote lecture. Thank you.
Thank you, Shazan. It's super good. Oh, good. Is it in presenting mode? That's perfect. Looks good. Well, thank you so much for that kind introduction. And let me just say, I couldn't wait to come here to Aga Khan. I've known about Aga Khan for many, many years. And just being here physically and just getting a chance to meet everybody here and feeling the energy and the vitality and the creativity is spectacular. That starts at the top, as Salim said, Dr. Inam, remarkable leadership. I know something about leadership, and the tone is set at the top, and you're an inspiration to generations of neurosurgeons here. The students, you know, speak of you in incredibly glowing terms, and I can see why. So thank you for the invitation. You know, you mentioned that increasingly it's becoming a global, the world is becoming increasingly connected. So I thought I would give you a sort of some reflections on experiences that I've had and we've had with some of our faculty and residents and teams over the years, developing relationships in Tanzania. But before I do that, I want to invite you to our home city, which is Nashville, Tennessee, which is known as Music City. It's not just country music, and we don't call it country western anymore. So just get rid of that statement. It's country music, but it's actually all music. It's a very vibrant city. It's one of the most rapidly growing cities in the United States. It's a very friendly city. We are embedded on the Vanderbilt University campus, which is a fantastic opportunity for us to collaborate with colleagues at VU and engineering and other disciplines. The medical campus is right there. We're deeply connected, and it's growing as well. It's a beautiful campus. We take really good care of patients there. As you mentioned, there's a deep connection between Vanderbilt and Aga Khan, and I wanted to highlight a few before I start on my talk. One was Imad Khan, who was a cerebrovascular research fellow with us, who went on to complete his residency in neurosurgery at Dartmouth and is now doing a spine fellowship at the University of Washington. Inam was a research fellow in our labs in the spinal outcomes research, and recently matched in neurosurgery residency at the University of Missouri. He's just a spectacular person, just irrepressibly positive. I don't know if many of you remember Monib Edasham. He was here many years ago, but I've known Monib for over 20 years. He's absolutely brilliant. He originally came to work in my research lab, wrote his first grant, which was an NIH R01, which got funded. He joined the faculty and then decided he wanted to train in neurosurgery and matched with us. He's now an associate professor of neurosurgery at a new program in Creighton University in Nebraska. More recently, we've had a spectacular grad, Sonia Goodell. Many of you may know her or remember her. Sonia is remarkable. This is a picture of her and probably in her element leading the teams. She trained with us and then was very accomplished during her residency and went on to do a very prestigious skull-based fellowship at Ohio State with Danny Prevedello. We took this picture on one of her last days. This was Sonia operating with me in her last case. She's now on the academic track and just joined Cooper Medical Center, which has a brand new program as well. And she's an assistant professor of neurosurgery there. So I'm really proud of her. I also just want to say how impressed I am with the students here. Incredible. I feel like they're the crown jewels here. You really get that sense. And I just want to thank all of the students for their hospitality and make mention that Aisha came and visited us. This is a picture of her in my clinic this spring in April. So let me just say that I wanted to begin this talk about global neurosurgery and my interest by speaking about my father. My father was the first in his family to go to college. He grew up on a farm in Oregon, in very rural Oregon. He got a PhD at Cornell and then became an international research scientist. And he took our family to really remote places. When I was 4, I lived in northern India, in Uttar Pradesh, and I have memories of that through the eyes of a child. He took our family to Indonesia, where he lived in central Java for many years. And then I was fortunate to go to school in Malaysia. My dad worked for the Rockefeller Foundation for a period of time for a program called Education for Development. And what he was interested in doing was developing research programs for graduate education in countries like India and Indonesia, and doing research. And what I realized is that that was probably ingrained in me, and I think sparked an interest in our mission in our department, which is focusing now on global neurosurgery. And so why international neurosurgery? Well, it's integral to our mission, as I said, and its focus really ought to be on education. It's about establishing connections and fostering research opportunities. What are the benefits? What I've learned is that there's tremendous benefits that come from teaching and collaboration, just meeting new people, learning to think and solve problems in different ways. It's very creative, lets you get out of your routine and comfort zone, lets you see new things. It also allows us to recruit faculty with particular interests in global neurosurgery. And one of the real leaders in that area is sitting right here, Michael Dewan, who trained with us and then went to Toronto. And then we were fortunate to have him come back and join the faculty. And a big reason that Michael, who could have gone anywhere, came back to Vanderbilt was, I think, that he saw opportunities there to expand his interest in global neurosurgery. I've always thought that global neurosurgery, I thought the major need, and I still believe it is in trauma and pediatrics. But what I want to tell you is that I began to see that there's a role as well for someone with a skill set that I have, which is predominantly intracranial, and also intracranial neuro-oncology. Obviously, there's tremendous need for spine. But I didn't think there was a role for someone who could treat patients with brain tumors. But I wanted to talk about how I discovered that there was. We've had a rich tradition of having our residents travel and experience countries all over the world in neurosurgery. We have one of our pediatric neurosurgeons whose interest is in craniofacial reconstruction, brings a resident every year to Peru with a group of plastic surgeons. We've had individuals travel to Tanzania, which I'm going to focus on, Uganda, Zambia, and Sri Lanka. We've had faculty attend, physicians' assistants, medical students, pharmacists, nurse practitioners have joined us on these trips. Here's just a potpourri of our residents over the years who've traveled to Peru. They come back really with a new set of skills and a deeper appreciation for both what we have, in the States, and also what the opportunities are abroad. Here's a great picture of Dr. Dewan when he was a resident, spent a year in Uganda. One of our residents to the left there is Scott Zuckerman, who traveled with me to Tanzania. And as I'll show you from some of our travels there, was so inspired after that trip that he put off his spine fellowship at Columbia for a year and moved to Tanzania with his wife. Rebecca Reynolds spent a year, she wrote a grant and got that funded through the Fogarty Foundation and was in Zambia for about a year. Ahilan Sivignasan is originally from Sri Lanka. He's joined the faculty now at Jefferson, trained with us, interested in spine surgery, and unbeknownst to many of us during his residency, flew to Sri Lanka and set up a critical care course. Here he is with a group of nurses and faculty and students in Sri Lanka. We've had nurse practitioners and physicians' assistants travel with us, as well as Autumn, who is a pharmacist. And this is a picture of Autumn actually assisting her husband during one of the surgeries. You take on different roles when you have these adventures and ventures. There's a tremendous people coming in and asking us questions about critical care issues. My wife's a critical care doctor, so she's horrified when I'm telling her that people are asking me about critical care medicine. But you take on a number of different roles. So just wanted to highlight in kind of a visual way, which I thought might be interesting, our experience, my experience in Tanzania. It's if you have not had a chance to travel there, it's a very visually arresting country, very beautiful country. It's a population of about 60 million people. There's a growing number of neurosurgeons there. Over the years, they're increasing their numbers, but they still have a tremendous need there. We traveled through the country and in several different places, which I'll highlight. Mwanza here by Lake Victoria and Dar es Salaam and the island of Zanzibar as well. This was our motley crew looking fresh-faced in the airport in Nashville. I could show you a very different picture coming back 2 weeks later. But our first adventure was in Mwanza. It's just an incredibly beautiful town. You know, I'm used to showing up in the operating room and having all the instruments ready to go, but we had to peel through boxes and look for them and line them up and get them organized. And we met for the first time these two guys who are registrars, who I've become very close with and stayed connected with. And as you said, the world is flat, so we were able to do that now through WhatsApp. Mwanza is a Bugando hospital there. It's a very large teaching hospital, but the single neurosurgeon there told me that the catchment area is, for one neurosurgeon, 17 million people, which is just staggering. We had a chance to meet a number of people at that hospital, and these are some of the crew that were there. But Hans and Miso were some of my favorites, and I brought them some headlights, which are basically camping lights, but they were modeling them in this picture. You know, seeing patients in clinic, you realize you're seeing a potpourri of problems. Some are really intractable, some you might be able to help, some might not. Scott was a real expert in spine, and so while he was off doing spine surgery, I was and teaching some of the registrars here some spinal instrumentation techniques. I really started off, you know, doing some simple things just so I could get my feet wet, if you will. And so here I'm doing just a shunt, and here doing a shunt with no cautery. But the amazing thing to me anyway was that I was doing a shunt on a baby while they were delivering a baby in the next room, which was staggering to me. We realized, and it was also staggering to me, that there were people, you know, lying around, including this patient who had an open depressed fracture with meningitis, who in the States would have just been treated within a couple of days and then home with home antibiotics. But we were able to do what I thought was a pretty elaborate operation, and gratifyingly, patient did really well. The first large intracranial surgery I did in Tanzania was my first trip, was this young man with this large brain abscess. And, you know, it was quite an extraordinary experience here, doing the case with Hans, one of the registrars. And just realizing sort of the fact that when we dropped him off after the surgery, here he is post-op day one, I couldn't sleep at all, because I'm used to having a neurosurgery ICU with 34 beds and plenty of nurses and intensivists. And there was somebody sitting behind a desk there. And I wasn't sure if he was going to make it through the night, but here he was the next day. And it was just an uplifting, elating experience. So at that point, I felt like there was some opportunity perhaps to, you know, consider treating some more complex patients. And this patient came in and they presented it to me, and with some trepidation, we thought that we had the tools to go ahead and treat this patient. But we found a drill, and we were ecstatic about that. It was in a box, but they plugged it in that morning, and, you know, it was the wrong electrical configuration, so that drill exploded. So it took a minute for us to get the craniotomy off, and fortunately we were able to revert to you know, more rudimentary neurosurgical skills, which here is being demonstrated by one of the registrars, Hans. But nonetheless, we were able to treat that patient. And then on the second trip, even a more complex meningioma patient who had this tumor, and we felt comfortable operating on him at that time. And here we are doing that case. We brought over some mesh to reconstruct the bone. And here he is post-op day one. And I asked him specifically to hold up his right thumb because he was seizing preoperatively, but he'd done extremely well. I think, you know, I began to learn at any rate that there was some possibility to treat more complicated problems. And there was also a need to help educate our colleagues about that. And so I love this communication that I had. This is another patient that I was back in the States, and Miso sent me this picture, and I said, wow, it looks like a large meningioma. It should come out. Do you want to send it to Dar? And he said, it is already out, sir. I did it. The patient is quite well, no hemiplegia, able to talk, just doing physio now. And I said, whoa, that is absolutely incredible. Miso, you're the man. He goes, thank you, sir. Though it was not easy. Some things we saw, I just don't even know what this is. And I don't even know how to begin to think about a problem like this. Obviously, that wasn't something that we thought we could handle, which is sad. This is a young child. I still don't know what that is. We developed relationships there. They got me a cake on my birthday with a Tanzanian flag, and loved that. I met some really fabulous people. We traveled city. Here we are, looking a little shell-shocked, landing in Dar. I almost got arrested taking this picture, which is why I think I like to show this picture, because this was hard fought. Apparently, you weren't supposed to be taking pictures on the ferry, but they have a large hospital there. It's an orthopedic institute. And on our second trip there, I was presented with a patient who was losing vision from this tuberculum meningioma. And in the background, you could see Scott Zuckerman, who basically kind of coerced me into doing this operation with the teams there. I was really nervous about it, but they have some pretty sophisticated equipment. They have a nice microscope and fabulous anesthesia. So we thought we could do this operation safely. Here it is, just sort of showing you the complexity of this tumor. And so we tackled that. Interestingly, there was a colleague of mine who's chair at Colorado who happened to be overlapping with us, and he was kind of questioning whether he thought that was a good idea to do this surgery or not. But we did it, and actually, I think it went quite well. Here I brought over some cranial plates, and the scrub tech here, I wanted to teach them how to use those plates. Previously, they just set the bone in. They don't sew it in or plate it or what have you. But it was kind of an experience to be able to do that. Then Scott and the team presented this patient to me who had a previous attempt at treating this meningioma through a midline incision, and I just didn't think they were really able to do much, and she was declining. As you can see, it was complicated. The vertebral artery was sort of running through it. So I thought that we could potentially do an operation designed to decompress the brainstem here, but not really enact a complete resection of that tumor. Again, with some trepidation. I think this is a formidable case, even in Vanderbilt for sure. But nonetheless, we put the patient in park bench, and you can see our planned incision there, and carried out this surgery really safely, and the patient did fine. We traveled to Zanzibar, which I don't know if anyone's ever had an opportunity to go there, but it's just an incredibly beautiful place. This is a picture I took on my iPhone from the operating room at Zanzibar, and I'll show you a couple of pictures of that. You can see here's the OR, here's the view of the Indian Ocean out there. Just an incredible culture, sort of an otherworldly experience being there. A lot of history, beautiful architecture there. This is a freestanding hospital. It's a neurosurgery hospital that was put up by a group of Spanish neurosurgeons. They rely on teams of mission teams to come through every month or so. And they're staffed there. And in the top floors are the operating rooms up here. And these are the ORs, and then these are the wards, and then this is the clinic. And it's set on the campus of a hospital in Stonetown, which is the main town there. This is the team of some of the registrars and the nurses and the administrators and anesthesia and the techs. Very skilled anesthesia. They have 2 ORs, and we were able to, I think, do some safe surgery and both help patients, but also provide some educational opportunity for the teams there. This was a case that we did that I couldn't even imagine doing this maybe the first trip, but with some confidence. This was a patient with it turns out to be a thoracic ependymoma that was declining. It was pretty weak in his legs, but not complete yet, and also starting to get weaker in the arms. So they have a microscope, and we were able to take it out. Here's a patient who had a very large, complicated meningioma, and again, here you can see us attempting to remove this there in Zanzibar. I remember they had rain eclipse, and at the end of the case, I was just going to take them off, and they were flying around the room. And my partner, Chris Bonfield, goes, they reuse those. And I said, oh, yeah, okay. So, it's really learned a lot. This is her post-op day 1. Thankfully, she did, really well. I think, One of the more satisfying cases actually wasn't a large tumor, but it was this young man who had what I think was an osteoid osteoma. It's very painful for him as he would pray. We saw him on the first trip there, but we didn't think that we had an opportunity to treat him. But he came back on our second trip, and so we did pretty straightforward operation. Tried to stay out of his frontal sinus and just drilled that flat down. And this is him post-op day one. Actually, I think the word is that he did extremely well, and he was just very grateful, as was I. There were challenges. At one point, we got an email they'd run out of oxygen at the hospital. So the intrepid individuals there, realizing that Zanzibar is a diving mecca, went to the dive shops and got some oxygen tanks, and so somehow we were able to manage to finish doing the surgeries for the week. What I want to end with is to say that I think that I'm learning more and more about what it means to have connections and establish deep connections with colleagues in places like Tanzania. And we're learning how to do that well, I think. Still learning, however. I think it's important to engage local providers. You need a lot of support for this. As I said, we've really made it our mission, but how do we sustain that? How do we fund that? I think philanthropy is going to play an important role for that. It takes recruiting talented young surgeons like Michael Dewan, who are focusing on the challenges of global neurosurgery, and have written extensively and have approached it in a very scientific way to help us gain research funding for efforts like that, and to further establish our connectivity. So what have I learned? I learned there is a role for an intracranial neurosurgeon who doesn't do spine particularly, or even general peds, frankly. I think you need to be very mindful of what you can do. I showed you some cases that I didn't think I could do, but I think I felt our teams could do them safely. I think I've learned, as I did growing up, that it's very important to be mindful of cultural differences, and to recognize that governments prioritize different things. I've also learned some resilience and some adaptability. I came back really a different surgeon. I remember the first day back in the OR at Vanderbilt after my first trip, and everything about the OR felt different to me. The gowns were really light. There was light. People were handing us instruments. These bipolars don't meet. Can you please get me another one? And it just felt foreign to me being back in the States. So I think I'm a better surgeon. I think people I know who've done these, have had these experiences, have come back. I was complaining one day about something, and one of my junior partners said, "You just need to channel your inner Africa." I think I was complaining that we didn't have the image guidance we needed. And the reality is we could do the case without it. But I think there's a challenge of sustainability here. What I'm interested in is providing educational opportunities for some of those young registrars in Tanzania. I'd like to have them come rotate with us. We'd like to be able to help uplift them in their educational mission. And I think that started with my dad's focus on education for development. So let me just close there and close with a very large thank you for allowing me to speak to you about a passion of mine. But moreover, thank you for your kindness and hospitality and welcoming us. It's just a delight to be here. As I said, we have a rich history between our two institutions. Everything I've always heard about Aga Khan, I came with a certain level of expectation, and it's just, frankly, just exceeded that. So thank you very much.
Professor Thompson, that was just an amazing lecture. Talking about the experiences. There's something about Vanderbilt. People from Vanderbilt go out to all these places and provide this unique services. So Netherville is also one of those people, right? And Mumtaz Jamshed Khan, who happens to be the class fellow of our chair of surgery, also goes there on a regular basis. And I think we should build up on that. And we do definitely do these kind of things in Pakistan, but I think the Vanderbilt is probably more experienced and can organize things better. So we should work on that one. So thank you very much. And thank you, Dr. Shazad Shamim, for introducing Professor Thompson. So our next speaker is Professor Tracy Batchelor. Professor Batchelor is a neurologist, and he's a professor of neurology at Brigham and Women. He was at Mass General. He did his medicine from Emory and his training in MGH. And he specializes in targeted therapies, molecular aspects of neuro-oncology. And whenever I look at his research, I think that, wow, if I could do something like that, one day maybe I will. When I met him in China a few years ago, and I was impressed by his work, by his talk, and also by his personality. Such a nice and mild person, very easy to get along with. He is also the president of SNO at this point, and I think the SNO is going to make great advances under his presidentship. So, Professor Batchelor, we are ready to hear your talk on targeted therapies. Thank you very much for being here.
Thank you. Thank you for that kind introduction and for the opportunity to participate again with all of you for the third annual Neuro-Oncology Symposium. I hope one day to be there in person for this. Let me share my screen here, and then we will get going. I hope that you can all see my slides. Great. Okay, thank you very much. So I'm going to talk today about what I think is a very exciting time in neuro-oncology. And I'm so pleased that the pediatric neuro-oncologists are there, because a lot of what's really exciting about targeted therapies for nervous system tumors is beginning in the kids and in pediatric neuro-oncology. And you'll see some of the examples that I will talk about today are pediatric tumors. So this is where it all begins. And on this slide, this is a slide from part of the NCI website where they identify high priority molecular targets in cancer. And what you see on this slide represents decades and billions of dollars of work and investment to understand the molecular wiring of cancer cells and different cancer types. And it has unearthed a plethora of targets for us that drive different types of cancers, and it has unleashed unprecedented development in drugs that will target these molecular nodes, and has led to many approvals and improved outcomes in various types of cancer. We're not necessarily there yet in neuro-oncology, but the door has been cracked open, and we are absolutely going to get there. And as you'll see, we have a number of FDA-approved drugs now, and that will only accelerate. So I'm going to talk about that. I'm going to talk about the success stories, our current FDA approvals for nervous system tumors of targeted agents, targeted drugs. So just to run through some of these, this was the first example, and this dates back to more than a decade, when the FDA approved an mTOR inhibitor, everolimus, for subependymal giant cell astrocytomas that occur in the context of tuberous sclerosis. What is tuberous sclerosis? It's a rare condition, an autosomal dominant genetic disorder, and it's characterized by dysregulated mTOR signaling. So there was much interest in applying mTOR inhibitors in this condition. So this was there was a phase 2 trial, again, more than a decade ago now, 23 patients, where these patients had growing subependymal giant cell astrocytomas. And these are tough tumors because they occur in the lining of the ventricles. So they're difficult to access surgically and remove. They're usually multiple tumors. They cause significant morbidity, hydrocephalus, seizures, et cetera. So a big problem for these patients with this condition. So in this trial, everolimus monotherapy was administered, and more than 50% of these patients had partial responses. What's a partial response? A partial response is 50% or greater shrinkage of a tumor by MRI or CT. So a pretty remarkable finding for a single drug, a monotherapy in this type of astrocytoma. Importantly, it had functional consequences. Seizure control, seizures are a big problem in tuberous sclerosis. Seizure control improved in a significant fraction of these patients. So the FDA approved everolimus initially in 2010 and confirmed it in 2018 after long-term follow-up. And importantly, you know, some of these target therapies do have side effects, right? Well, in this case, patients were able to stay on the drug for 5 years or more, 67.8 months, and no patient discontinued because of an adverse event. So this is approved and is used for subependymal giant cell astrocytomas in the setting of tuberous sclerosis. So here's another approval that occurred just a few years ago. And this is one of these examples where there is an approval for cancers with specific genetic alterations. So it's disease agnostic. So in this case, this is a drug, larotrectinib, which is a TRK/TRK inhibitor, which was approved for any kind of solid tumor that had an NTRK gene fusion, which is felt to be a driver event in several kinds of tumors, breast cancer, among others. Well, we studied glioneuronal tumors a few years ago and showed that in about 30% of glioneuronal tumors, there are fusion events, and many of these do involve the NTRK family. So we enrolled some of our patients with NTRK fusions. These are patients with glioneuronal tumors in a trial of this NTRK inhibitor, entrectinib. You can see this was a phase 1 dose-finding trial, but you can see an example in the top panel. There is a high-grade glioneuronal tumor that had failed radiation, it failed chemotherapy, and we treated with entrectinib monotherapy. And you can see on the MRI below, 4 months later, there's a pretty dramatic response of the tumor to this agent, and the patient was able to come off dexamethasone, seizure control improved, so functional improvements as well. Unfortunately, this patient goes on to progress later and eventually does die of this tumor. But I do think this is proof of principle that this drug clearly has activity. A companion drug, larotrectinib, is now available. It's an oral therapy, and we can use it for any type of brain tumor that has an NTRK fusion. Moving right along, another approval just a couple of years ago, FDA approved selumetinib, which is a MEK inhibitor for patients who have plexiform neurofibromas. So this occurs in the context of neurofibromatosis type 1, autosomal dominant condition, leads to dysregulated RAS signaling and MEK hyperactivation. So this is a MEK inhibitor trial, but these patients have these plexiform neurofibromas that can be painful. They cause disfigurement and dysfunction. So in phase 1 trial in children with plexiform neurofibromas, 70% of patients had partial responses. These are the waterfall plots over here. You can see significant reductions kind of across the board at different doses. You can see over here, I'm just trying to get my screen configured here. You can see that in one case, there's this disfiguring tumor in the leg and pelvic region. And you can see with time, with treatment with selumetinib, this tumor burden significantly reduced. These seem to be durable responses. So this is approved for NF1-related plexiform neurofibromas. There's another drug, mirdametinib, which has been studied in older patients with NF1-related neurofibromas and also shows a high level of activity. And that may also gain FDA approval. Moving right along, another one. So this is a very recent approval, about a year ago. The FDA approved a HIF alpha inhibitor, belzutifan, for cancers that are associated with another genetic condition, von Hippel-Lindau disease. And von Hippel-Lindau disease is characterized by hemangioblastomas that can occur in the eye, but also can occur in the brain, in the cerebellum, brainstem, spinal cord. The main cause of morbidity in these patients are the CNS hemangioblastomas. So loss of the VHL gene leads to activation of HIF-alpha, which leads to angiogenesis, cell proliferation, the formation of these hemangioblastomas. A trial was launched of this oral HIF-2 alpha inhibitor, phase 2 trial, in patients who had VHL and in this case, clear renal cell carcinoma. That was the specific indication of the trial. There were 61 patients enrolled. About 50% of those kidney tumors had responses, and 24 patients of these 61 also had measurable CNS hemangioblastomas. And among those, 60% had objective radiographic responses. And these also, again, appear to be durable. The median duration of response had not been reached, and most patients have been treated for more than 1 year. So this is now FDA approved, and it's available. Just a couple of months ago, the FDA granted approval to a combination of a RAF and MEK inhibitor, dabrafenib, in combination with trametinib for any kind of solid tumor that has BRAF V600E mutations. As you know, there are gliomas, different types of gliomas that have BRAF V600E mutations. So this drug is now available for those patients. It's approved. This was based on 3 trials of 130 adults and 36 children who had BRAF V600E mutant tumors. And in these, among those tumors, there were a good number of high-grade gliomas. The overall response rate to this combination was 36% in high-grade gliomas and 50% in low-grade gliomas. So again, active agent and available for use in these patients. So those are some FDA approvals that have come in the last few years. I want to talk a little bit now about future prospects of oral targeted therapies for brain tumors. And this is work that we've done at our place. This is a drug called tovorafenib, which was granted breakthrough designation by the FDA just recently for pediatric low-grade astrocytomas. Pediatric low-grade astrocytomas, this is work that comes out of our SPORE grant, are driven by BRAF oncoproteins. The majority of these events are not the canonical point mutations that I just talked about, the V600E mutations, but these are actually, again, truncation fusion events. So the type 1 RAF inhibitors that work for V600E tumors do not work on this truncation fusion RAF altered tumor. So we, in an exercise that started our SPORE, really with a drug screen and a medicinal chemist, identified a type 2 RAF inhibitor that's brain penetrant and seems to suppress all forms of this RAF oncoprotein. This is tovorafenib. So this is some of the work that was done to establish it. So it's a type 2 RAF inhibitor. This was moved into a phase 1 clinical trial in patients with RAF altered pediatric low-grade astrocytomas. This is phase 1 trial. And you can see from the waterfall plots here that even though in a phase 1 at different doses, there were clearly some responses. And some of these were rather dramatic responses. Some of the MRIs are on the slide there. So this led to a larger study that was called Firefly-1 of tovorafenib in relapsed or recurrent pediatric low-grade astrocytomas. This was just presented at the ISPNO meeting in Germany a couple of months ago. So these are the waterfall plots on the 22 patients, and you can see that almost every patient but one had some type of response. 64% qualified for partial responses. So it appears to be an active drug. It has now been moved into the frontline setting, and there will be a randomized phase 3 trial against chemotherapy in the frontline setting of pediatric low-grade astrocytoma. This is an example from one of the trials of a optic pathway glioma that has this truncation fusion event. And you can see that after treatment with tovorafenib, there's a reduction in size of this tumor. Okay, so another area where I think there's significant promises in IDH mutant gliomas. So these are these are diffuse infiltrative gliomas. You can see here from an autopsy specimen, there's a bulky mass of tumor here, but all of these dots are IDH positive or mutant cells. This points out the infiltrative nature of gliomas. And while we desperately need effective local regional therapies like surgery and radiation, we're not going to solve the problem, however, until we develop a systemic therapy that's going to be able to reach these cells in remote parts of the brain. So there's an interest in targeting IDH. So the IDH mutant gliomas, this is a gain of function mutation in these tumors, and it leads to the accumulation of this 2-HG oncometabolite. You can detect this mutation by immunohistochemistry in about 95% of patients. You have to do sequencing to pick up that final 5% of mutant patients, but in the vast majority, immunohistochemistry works. The mutation is present in about 70% of all low-grade and anaplastic gliomas, and it's present in 10% of grade 4 gliomas. I mentioned the oncometabolite, the 2-HG. It accumulates at very high intracellular levels, so you can actually measure it non-invasively with MR spectroscopy. This is work done by our team as part of the SPORE project, showing that in a mutant anaplastic astrocytoma, you see this 2-HG signal here, whereas in our controls, where a wild type, there's no signal, and in a healthy control, there's no signal. So we've used MR spectroscopy as if you will, a biomarker in some of the early trials. So this was a trial of a first generation IDH1 inhibitor, and it didn't work. The drug did not seem to shrink the tumors, and the tumors continue to grow. So we always ask ourselves, well, is that a problem with the drug getting to the target and engaging the target? Maybe it's a delivery problem, right? So we were able to show in this case it was not a delivery problem because we measure 2-HG levels before and after treatment with this IDH1 inhibitor. And the blue curves are before treatment, the red curves are after treatment, and there's a right to left shift, which means that there's a drop in the 2-HG levels. So very clearly, this drug is getting to the target, engaging the target, modulating the target, but it's still not working. But there is reason for some optimism because now there are second generation IDH inhibitors that appear to be more potent. So one of them is vorasidenib, which is a brain penetrant inhibitor of IDH1, IDH2. And in early studies, about 30% of gliomas with IDH mutations have had objective partial responses. And this is also correlated with reduction in 2-HG. So a double-blinded, randomized, placebo-controlled phase 3 trial has been launched. And the good news is that at an interim analysis just a couple of months ago by the Data Monitoring Committee, they concluded that the trial should continue and complete enrollment. I think, when you have these interim analyses, there's a futility analysis that is done. And if that futility analysis shows the drug is not working, they will close the trial. So in this case, that apparently was not the case, and the IDMC recommended the trial to continue. So that's encouraging, but we'll have to wait for final results to see if this drug is going to be effective. Okay, last tumor I'll talk about is craniopharyngioma, rare intracranial tumor, but it's one that's also associated with a particular genetic alteration. So this is work done by Priscilla Brastianos at our institution with her colleagues, and she showed that the papillary form of craniopharyngioma, about 95% of them will have a BRAF V600E mutation. So she launched this trial of a phase 2 RAF-MEK combination in patients with papillary craniopharyngiomas with BRAF mutations. This was presented at ASCO, the paper's in presentation. Very clearly, this is a highly active drug. 15 of 16 patients had partial responses. And again, that's at least 50% shrinkage of the tumor. So this is not yet approved, but this is really strong data. We'll see whether this drug also gets approved. So to conclude, we are really in the era of precision neuro-oncology. We've identified, the community has identified multiple oncogenic signal transduction pathways in pediatric and adult gliomas and other types of nervous system tumors that are targetable. We don't worry as much about blood-brain barrier penetration because in the modern era of medicinal chemistry and engineering, we can manufacture highly potent brain-penetrant oral drugs. We have 6 oral targeted drugs that are now FDA approved for nervous system tumors, 5 of them since 2018, and there are more in the clinical pipeline. I did not talk to you today about a number of these, the H3K27 mutant gliomas, which are diffuse midline or diffuse intrinsic pontine gliomas. There's a targeted drug that seems to be working somewhat in those tumors. There's also interest in smoothened and AKT inhibitors for about the 15% of meningiomas which have alterations in these genes. BTK or Bruton's tyrosine kinase inhibitors appear to be very active in primary CNS diffuse large B-cell lymphoma, and there are a whole host of targeted inhibitors that are under study for molecular subtypes of CNS metastases. So we will begin to enter this the next phase where we will compare some of these newer oral targeted therapies against some of the more traditional cytotoxic chemotherapies and radiations. And those trials are underway. And I mentioned one already in pediatric low-grade astrocytoma. And of course, the hope is that generic versions of these drugs will eventually emerge and that they will become more affordable. And we will be able to see more widespread usage of these drugs. They're oral drugs, so they don't come with a lot of the complications of more complex therapies. But of course, we also recognize that resistance often develops and that we'll have to figure out what pathways get turned on in these resistant cases, and combinations of these drugs will likely be necessary. And so for that, I thank you for your attention and for the invitation to participate.
Thank you so much, Dr. Bachelor, for such an excellent talk. But I was just wondering that in our part of the world, for LMIC, what will we do without all these targeted therapies? We don't have much options. If we talk about even dabrafenib, MEK inhibitors, although we do have a everolimus and we have used it quite often, but the rest is like a big mountain, like an Everest to achieve in our part of the world. So maybe at some point in time, you may have, like with collaboration, we may have some clinical trials which will be open in LMIC. So, many children will be benefited for all these targeted therapies. Thank you. So I've been given the task to introduce Dr. Amar Gajjar, our next speaker. So Dr. Gajjar is the chair of Department of Pediatric Medicine, co-chair of the Department of Oncology, and the director of the Neuro-Oncology Division and St. Jude's Children Research Hospital. Dr. Amar is the leader of the hospital's neurobiology and brain tumor program, and one of the 5 cross-disciplinary and multi-departmental programs at St. Jude's Comprehensive Center. He's the principal or co-investigator in many of the several innovative clinical trials of new treatment in pediatric brain tumor with more focus on medulloblastoma, PNETs, and ATRT. Dr. Gajjar has been instrumental in the growth of neuro-oncology program at St. Jude's and in developing international collaboration with Australia, Canada, and other leading institutes in the USA. Dr. Gajjar also works to develop key bridges between the clinical research and lab-based research program within the neurobiology and brain tumor program. He's co-author of more than 300 papers, of which have contributed significantly in the improvement of clinical care of children with brain tumors. And the topic he's talking about is what has history taught us, taking new treatment into clinics for children with brain tumors. Thank you so much, Dr. Amar, for accepting this keynote lecture, and then over to you.
Dr. Gajjar, you are on mute. Thank you, Noreen, and thank you to the organizing committee for inviting me to give this talk. Can you hear me now? Can you hear me?
Yes.
Okay. So what I thought I'll do this morning for in the next 20 minutes is give you two vignettes of how we are introducing new treatments for these molecularly defined tumors, but how we need to keep in mind what history has taught us. So I'm going to give you an example of treatment for medulloblastoma, specifically Wnt medulloblastoma, and then discuss high-grade glioma, again, a molecularly defined group of patients which have a hypermutator phenotype. So as you know, well, that recent data now more than a decade ago has shown that medulloblastoma is not a single disease, but actually a compendium of 4 distinct molecularly defined subgroups, mostly Wnt, sonic hedgehog, group 3 and group 4. And now more data coming out with molecular classification, further subdividing these main groups into subgroups. And I think the most well-defined ones are the sonic hedgehog, where we have 4 subgroups, and then the group 3 and group 4, which have 3 subgroups each. And with methylation profiling, some people say even 8 subgroups. So what I'm going to focus on today is the Wnt medulloblastoma. So the molecular features of Wnt medulloblastoma are as follows. We have a beta-catenin mutation present in 96% of these patients, which is the defining mutation of this subgroup. We also have mutations in the DDX3X gene, the SMARCA4 gene, and a small percentage of patients which have a p53 mutation, about 8%. And the cytogenetic definition of Wnt medulloblastoma is loss of chromosome 6, which we also define as monosomy 6. So this particular tumor clinically has a female predominance. It is present in children who are older. Median age is 9.6. Histology is classic. FISH, as I mentioned, shows monosomy 6. Immunohistochemistry shows nuclear beta-catenin positivity. And I think just between the FISH and the immunohistochemistry, this is routinely available in LMICs, we can make the diagnosis. If you sequence the beta-catenin gene, you can have mutations in exon 3. And this particular subgroup has an excellent outcome, even for patients which have metastatic disease. So there has been a temptation of trying to reduce therapy for this Wnt subgroup. Just a little bit of biology. This tumor arises from cells from the lower rhombic lip, and these cells proliferate and then rotate and come to the dorsum of the brainstem, as you can see, which is illustrated in the panel to the right of your side. And this is the MRI presentation of a Wnt medulloblastoma, which is typically a midline tumor sitting in the fourth ventricle and enhancing. There is about 10 to 15% of these patients which have an atypical presentation, where these slow proliferating cells from the lower rhombic lip do not completely rotate and go into the fourth ventricle, but sort of arrest their migration. Then you can have this atypical presentation of a CP angle tumor. So this is an example of an atypical presentation. This was a teenage girl who presented to our institution, and you can see the CP angle tumor. And I got a call from the operating room from our surgeon, Dr. Boop, who said, listen, I think I'm not going to be able to take all this tumor out. This girl was an athlete and a basketball player He said, if I take this much tumor out, it's likely that this girl will be wheelchair bound and have severe ataxia. So he left a certain rim of tumor. You can see it on the FLAIR image on the left side, and you can see the restriction on imaging on the right side of the slide. Now, again, a little bit of biology and how this helps us with our patient management. So typically you can see normal neural cells secrete Wnt7a, and that helps to maintain an intact blood-brain barrier. With medulloblastomas, they secrete WIF1 and DICOF1-4, which inhibits Wnt7a, and these patients have a very leaky or almost an absent blood-brain barrier. So one of the clinical tip-off for that you're dealing with a Wnt medulloblastoma is the surgeon will call you and say, listen, I had unusual blood loss in the operating room. And if it's a female, older patient, you slowly start thinking, okay, this may or could be a Wnt medulloma. But how do we use this therapeutically? Because these tumors have a very leaky or absent blood-brain barrier, they are exquisitely sensitive to chemotherapy. So this is this girl's MR imaging after 2 rounds of very simple chemotherapy. And when I went back and discussed the imaging with the neuroradiologist, he said, wow, she got a second resection and there's almost no tumor left. Well, this was a chemotherapy-induced resection of the tumor, not a surgical resection. So this is something we just published last October, the results of our Wnt medulloblastoma, and you can see these patients have an excellent 5-year survival of almost 100%, even though there are 7 patients for high-risk patients. And for the 8 to 10% of patients which have p53 mutations, they also don't seem to be affecting the outcome of the patients. And you can see this is a series published from investigators at Sick Children in Toronto. You can see the overall proportion of patients which are surviving in their discovery cohort and also in their validation cohort. So Wnt medulloblastoma really does extremely well with current therapy. The one thing to keep in mind with these Wnt medulloblastomas is there's a small proportion of them which have a germline APC mutation. And you can see that illustrated on your top bar over there, 7.6% of the patients which have a germline APC mutation, which seems to be exclusive from the patients which have a somatic beta-catenin mutation. So just something to keep in mind, because these patients, if they have an APC mutation, then they need screening for development of colon cancer. So again, I'm going to introduce this thought about colon cancer, and then I'll come back again during the talk, why we see colon cancer in these younger patients of ours. So globally, there has been an attempt to reduce the amount of therapy for these patients. There is a European study, PNUT5, which has finished accruing their patients, and we anticipate the results to be coming out very soon. So patients less than 16 years of age, they gave 18 gray CSI plus 30.6 gray to the primary site and 6 cycles of chemotherapy. The COG group in the United States is also giving 18 gray and a slightly higher dose of 36 gray to the primary site and 7 cycles of chemotherapy. And then we at St. Jude have been giving 15 gray CSI with 33.4 gray to the primary site with a total dose of 51.4 gray. So even lower dose of radiation therapy and only 4 cycles of chemotherapy for the subgroup. And we've also finished accrual, and we should be presenting our data pretty soon. So this is a very exciting time for this group of patients. They have a very strict eligibility criteria because people don't want to put the wrong patients on the study and then have an adverse outcome, because this will affect the study results. So I think these data now should be coming out soon, and we will have a new standard of care for Wnt medulloblastoma. But the point what I want to make now is while these studies were being done, the urge to try and reduce radiation therapy also has been attempted by two other groups. This is the group from Tata Memorial Hospital, headed by Dr. Jalali, who's a radiation oncologist. And they had a study which was just published in Clinical Cancer Research, as you can see, which tried to omit upfront craniospinal radiation in patients with low-risk medulloblastoma. And the title actually gives what happened, that we had unacceptable high-risk neuroaxial failure in these patients. So you can see in this imaging panel that the patients had metastatic failure with local RT. You can see this metastatic tumor intrahemispheric, and you can see spinal metastatic disease in the lower lumbar cord and in the thecal sac, which is highlighted by the arrows. And unfortunately, they had 7 patients enrolled on the study, and you can see at 2 years what was a curable disease with almost 100% survival at 5 years. The event-free survival dropped to almost 40%. Another study, again, this results were published in an abstract form, was one which was done in the United States from the group at Hopkins and at Boston Children's. And this is what happened. There were 6 children enrolled on the study. This study basically wanted to avoid all radiation therapy, so only gave chemotherapy. Subject 1 and 2 completed planned protocol, but relapsed 3 and 6 months following completion of therapy. In both cases, the relapse was local and disseminated. And with these 2 patients failing, the further accrual to the study was halted. Both subjects were salvaged with high-dose CSI and further adjuvant chemotherapy, but long-term outcome data, if they were truly salvaged, is still pending. Of the 4 remaining subjects, 2 recently completed planned protocol therapy at the time of study closure, and after the chemo, they both received craniospinal radiation therapy and remain in remission approximately for a year from the completion of treatment. But again, the follow-up is very short, and again, longer-term follow-up is needed. So 1 subject aborted the therapy and transitioned to a different protocol. And then the final subject, again, completed the chemotherapy, went on to receive CSI, and then again, subsequently relapsed. And now is receiving salvage chemotherapy. The last I heard was this patient was not doing well. So I think the lessons which are to be learned and what history has taught us is take a good history from the patient, pay attention to the family history and unusual familial incidence of cancer. This is to rule out APC gene germline mutations, because there'll be history of colon cancer at a very young age in these families. The genomic information guides therapy, and follow-up is important for patients with genetic predisposition syndrome. Always talk with the neurosurgery team about anything unusual at the time of surgery. And as I mentioned, these tumors tend to bleed. I think one thing which was drilled into me very early on is in my training by Dr. Boyette, who was my mentor and who was a statistician, always said, patients do well because of the therapy you give. So therapy is a key prognostic factor that determines outcome. So it was very important to realize that surgery, radiation therapy, and chemotherapy gave this result. So eliminating a key component of therapy, in this case, radiation therapy, the 2 studies discussed, is not a successful therapeutic approach. I think the other 3 studies, which I mentioned to you, with a gradual reduction in CSI, may be more beneficial, because these studies have now, 2 of the studies have finished their accrual. They've been monitored closely by the DSMB and have been allowed to finish their total accrual. So we anticipate their results. The second vignette I'd like to discuss is high-grade glioma with a hypermutator phenotype. So this is just a prospective, large prospective study which was done in the European consortium. It was called HERBI, which was a randomized phase 2 trial, which was published in Cancer Cell a few years ago. And I won't go through the detail, but they had basic randomization between Avastin and non-Avastin following radiation plus temozolomide and temozolomide for high-grade gliomas. And then the beautiful part of this study is that they detail molecular analysis. And what I am going to be really talking about, this small subset of patients which are hypermutator, which we all have probably seen and treated, but not really recognized clinically until recently, when we've had the molecular data which has been presented. So constitutional mismatch repair deficiency syndrome is a rare autosomal recessive disorder caused by biallelic germline mutations of the following genes: MLH1, MSH2, MSH6, and PMS2. This syndrome is characterized by extremely high risk of early onset of CNS tumors, hematological malignancies, and colorectal cancers associated with Lynch syndrome. That's the germline predisposition, along with dermatological signs reminiscent of NF1. So the key here is we talked about colon cancer in medulloblastoma with a completely different mechanism. And again, young patients with colorectal cancer or young patients with a history, familial history of colorectal cancer, again, should alert you that maybe this family has a Lynch syndrome or germline predisposition. And this is just an example of the neurofibroma kind of hyperpigmented patches which are seen on patients which have a Lynch syndrome. So CNS cancers account for about 1/3 to 1/2 of all patients with CMMRD. Among these, high-grade gliomas represent about 75% of all cancers in patients, followed by low-grade glioma and PNET and medulloblastoma. Patients with CNS cancers in CMMRD syndrome are not expected to respond to chemotherapy drugs, which we currently use, temozolomide, CCNU, and the response to radiation therapy is equivocal. So the diagnosis of this syndrome is commonly missed because of the rarity of this condition, lack of significant family history, and subtle genotype of these patients with deadly outcome associated with these cancers. So just to show you an example, this is a patient with germline biallelic homozygous MLH1 mutation. And this is a patient that we've been following in our clinic at St. Jude. And you can see in September 2010, on the FLAIR imaging, there was something which was present, on the brain MRI, wasn't significant. And then almost 3.5 years later in 2014, again, the FLAIR abnormality starts getting worse. And then within a short time of 7 months between January and August, you see this massive tumor which is growing in the parieto-occipital lobe. So this was sort of data which was published. All high-grade cancers with CMMRD syndrome were hypermutated by whole exome sequencing. You can see the tumor mutation burden in these tumors compared to normal childhood brain tumors and compared to adult brain tumors. And again, you can see GBMs have the highest mutations which are present. And you can again see the tumor neoantigen presentation, which is present in the GBMs which have mismatch repair deficiency syndrome compared to patients which have melanoma, lung cancer, and colon cancer. So this was a patient of ours who had underlying constitutional mismatch repair deficiency syndrome. You can see the tumor in the sagittal cut, in the axial cut, on FLAIR and on T2. And then you can see after giving a PD-1 inhibitor, pembrolizumab, this patient tumor on the sagittal cut significantly reduced in size. So this data was again recently published using immune checkpoint inhibitors as a single therapy for synchronous cancers exhibiting hypermutation. And this was a group which was led by Uri Taburi and his colleagues. This was an international study, enrolled patients from all over the world. And this were the results. So again, high tumor mutation burden, which is present in all the tumors, the initial and the subsequent tumors which are present in these patients. And you can see the numbers of tumor mutation burden excess of 100 in most of these patients. And this is a violin plot, which again shows between the mismatch repair deficiency synchronous and metachronous tumors, tumor mutation burden compared to the proficient tumors. And again, you see the total number of mutations and indels which are present in these tumors compared to the mismatch repair proficient tumors. So again, these tumors tend to have high proliferation, high exposure to neoantigens on their cell surface, and that is why they respond very well to these PD-1 inhibitors. So now I'm just going to present two vignettes which were published in this paper of patients with MMRT with synchronous cancer. So the first patient was a 13-year-old male. He had a PMS2 deletion, which was homozygous, and the synchronous tumors were glioblastoma and rectal adenocarcinoma. So the GBM was the first tumor. You can see it on the left-hand side of the slide. The presentation on the MRI. You can see the TMB, which is 318 mutations per megabyte, high number of neoantigens and high number of indels which were present. And the patient was treated with surgery, radiation, and temozolomide. And then 6 months later, he had a distal ulnar fraction and a rectal adenocarcinoma, at which point I think realization was made that his real diagnosis was CMMRD. He was put on pembrolizumab. He was given radiation therapy to his ulna. Then he had further mets in the spine, was treated with thoracic radiation therapy. And then he had widespread dissemination in the brain, and he died at 31 months post-diagnosis of his GBM. But again, this patient would have had a very early death had he had the right treatment not been initiated. So the second patient again was a young girl, 15-year-old girl. She had a compound heterozygous PMS2 deletion and a variant, and she had translational urethral carcinoma and an anaplastic astrocytoma. So again, you can see the first diagnosis of urothelial carcinoma. Number of neoantigens present was 14,475. You can see again, she was treated with surgery and kind of standard chemotherapy for this tumor. 3 months later, she develops an anaplastic astrocytoma, again treated with surgery and radiation therapy, was put on nivolumab, and then again lasts for about 38 months before she died. And again, she had dissemination of her brain tumor. So again, what has history taught us? These rare tumor subgroups have a unique biology and which may not clinically reveal itself. A good history and good physical exam may increase the index of suspicion. This is a skill that is, at least in Western countries, people are relying less and less on, but the old-fashioned good physical exam can still give us a lot of information. Key in order to have the right diagnostic test if index of suspicion is high for the disease. And in this case, it is a TMB, tumor mutation burden. Now I know in sequencing panels which are sent to reference lab, they automatically generate the TMB in that report. But again, in these kinds of patients, TMB is most important. And conventional therapy is ineffective. The use of effective therapy in this case is checkpoint inhibitors. And there are several of these products out there, and I gave you examples of pembrolizumab and nivolumab showing efficacy in these groups of patients. So in summary, what has history taught us? Detailed history and physical exam can reveal important clues regarding the underlying disease. Maintain high index of suspicion if there's anything unusual in the history or exam. Discuss cases with members of the team, neurosurgery, neuropathology, neuroradiology. Communicate with the lab investigators if there's some unusual finding. Molecular characterization of the tumor is essential for appropriate therapy in today's day and age. Dr. Batchelor also mentioned several of these tumors which have specific mutations which can be eligible for targeted therapy. At least in the US, we've got a requirement for clear certified infrastructure. And if it's not available in the institution, then most institutions send the material out to reference laboratories. This is expensive to set up locally. And again, subgroup therapy directed therapies emerging and will impact the cure rate gradually. And again, between Dr. Batchelor's talk and my talk, I think you're now seeing where the field of neuro-oncology is going, between targeted molecular derived therapies and then again adjusting traditional therapies in case of the Wnt medulloblastoma and introducing immune checkpoint inhibitors for the subgroup of patients with constitutional mismatch repair deficiency syndrome. So with that, I will conclude my talk. And again, thank you very much for inviting me.